Okay, thank you everyone for coming. I want to introduce our visiting professor in trauma. I don't have time to recite Mike Gardner's CV because there wouldn't be any time left for his talk. Mike's a New England boy to start with. He went to the finest liberal arts college in the United States, where he was an academic All-American. He played football and he captained the baseball team while graduating cum laude in chemistry. From there he went to med school in Philly. He did his residency at HSS in New York. He did an additional fellowship year at HSS. He won the A.O. Jack McDaniel Fellowship. He went on to do a trauma fellowship at Harborview in Seattle. He started his career at Wash U, where he was incredibly clinically busy while cranking out quite a bit of research. He has won multiple grants and multiple research awards, including Best Paper at the OTA more than once. He has made contributions across the board. After Wash U, he moved on to Stanford, where he is now the Vice Chairman for Clinical Operations and the Chief of Orthopaedic Trauma. Few of us can claim to be the authority on one topic, and Mike's the authority on at least two. In addition to that, he's been a good friend for a long time and has a lot of ties to this department. Please join me in welcoming Mike, who's going to talk to us about proximal humerus fractures. Try to keep it short.
Yeah. Well, that was certainly nice, Thomas. Thank you very much. And I do have a lot of ties to this department. It really, as I kind of got in last night and met with some of the faculty and then the residents and went through some cases and looking around, I realized how much kind of enjoyment and admiration I've had over the years for the University of Utah. It really is a pleasure to be here, and thank you all for coming this morning. So we'll talk a little bit about proximal humerus fractures. You know, I've kind of gravitated towards proximal humerus fractures as a little bit of a career focus. I've always found proximal humerus fractures are extremely complex and thought-provoking, and the literature is super interesting to read, and there's kind of two subspecialties in orthopedics who tend to treat the same fracture different ways, and we still don't know the ultimate answer. So anyway, we'll briefly get through some of these issues this morning. And not sure if I clicking something wrong. Okay, where's the keyboard? Looks like they're on, no?
Yeah, sometimes they don't want to.
Here.
Oh, there you go.
Mouse, okay. All right, so a little bit of just the agenda. We'll talk a little bit about treatment decisions and indications, very briefly on a few surgical techniques, and then there really is now a vast body of literature. We're just going to touch on a handful of what I think are potentially important papers. So very brief overview. You know, these are now becoming known as one of the osteoporotic fractures. We see a lot of these in geriatric patients. And of course, there are the young patient high energy varieties. It's kind of somewhat specific to the proximal humerus. These are difficult to fix. So their osteoporotic bone is kind of exacerbated in the humeral head. And then the shoulder joint gets very stiff, similar to maybe the elbow as kind of classic joints that get stiff. So we need to move the shoulder early, which means we need to fix well. And some things that are made difficult are the treatment decisions, technical execution, and technical execution. All right. So quickly looking at the fracture, we won't get into classification systems, also really a source of controversy, just to say mainly that the near classification, which many of us use frequently, has been shown to be relatively unhelpful when determining treatment and prognosis, for example. But just briefly, important to know the classification systems are based on kind of the classic parts or components: the greater tuberosity, the lesser tuberosity, the humeral head fragment at the anatomic or the surgical neck, and again, near of questionable value. So treatment principles really come down to patient factors, and this is the case really in any fracture, of course, but maybe more so in proximal humerus fractures, because these really come into play when we're determining what to do for the patient: the physiologic age, cognitive status, et cetera, et cetera. All right, so when we start trying to think about how we're going to treat a fracture, we start generally with kind of considering the X-ray initially, or at least as it happens sometimes in clinic or conferences. So considering the X-ray first, we start to look at stability, and stability is a little bit of a vague and hard to define term, but one component of it at least is displacement. And so displacement in the proximal humerus can be related to translation of the shaft or angulation of the head and neck component. And so varus, like many places in the body, varus in the proximal humerus is an indicator of more instability. And then also in the proximal humerus, we've learned a little bit over the past decade or so the importance of medial metaphyseal or quote calcar comminution as again a marker of instability. But the thresholds of these displacements that were, for example, laid out in the NEAR classification really don't hold. So this is an area where we don't really know how much displacement is critical to cross the threshold for the, quote, truly unstable fracture. So when we start assessing a fracture for its inherent stability, this is a little bit of a mental kind of thought exercise that we often run through at our fracture conferences. And it's not always easy to answer these questions, but some of the things that we'll think about. So we look at a fracture like this, we try to think, is this fracture likely to displace? So if we had the patient asleep under a fluoroscope and we ranged the shoulder, would it be likely that this fracture would move as a unit or not? And again, not always easy to figure out. Sometimes we indicate a fracture for surgery just based on the risk of non-union. And so if there's wide displacement, sometimes the best indication for that patient might be to attain healing. And so will this fracture heal on its own if we leave it alone? And then if it does heal like this, is a malunion of this magnitude likely to affect function? And so these are some of the things that I think are helpful to think about. Again, there's not clear answers many times, but these are also some of the things a lot of research is going into. A varus malunion of 20 degrees, does that affect forward elevation? These things are just not known quite yet, but things we have to think about when suggesting treatment. Okay, so then once we do a full scrutiny of the X-rays, we could start to consider the patient, and this is just the way my clinic runs. We'll often look at the X-rays with fellow or residents, so we'll kind of have a good look at the X-rays before seeing the patient. So it's actually can be very educational, because we'll come up with a whole plan based on the X-ray, and then you go in and you see the patient, and things change very quickly. So if your patient with this shoulder fracture desires, wants, needs a functional outcome like this, that's important to know compared to a patient who would be very happy, and there's very many of them who you guys have probably all seen, who with a shoulder forward elevation of 90 degrees, they would be very happy and they could get back to living their life. And so step one is important to get to know the patient. And step two, there are times when a displaced, unstable fracture, the treatment of choice is likely to be non-operative for medical reasons, a lot of reasons. And so it's important to have some sort of a sense of what the natural history of a displaced fracture that's treated non-operatively looks like, because it needs to be part of the discussion. Many will talk about mostly fixation and ORIF today and some arthroplasty, but non-operative treatment is used really in the majority of patients. So we need to know how to discuss the natural history of non-op. And then really we want to ultimately avoid more than anything this situation where we think the patient has a problem that we can help with, and we think we have the tools to help them, him or her, and then turns out we have failed the patient. And so this is all this decision-making and branching of choices really is to ultimately avoid this. So it's really important to critically assess your ability, your awareness of the fracture, and your kind of toolbox to fix a fracture. And so risk stratifying fractures will be a little bit of what we'll talk about in just a minute. All right, so briefly on non-op. So there's actually a fair bit of literature on non-op treatment of proximal humerus fractures. Here's one. Outcome for type C, so the AO classification, kind of a comminuted or multi-part proximal humerus fracture, comparative study, and there are many of these comparative studies, but here was just a good graph to show. So it is important to realize while non-operative treatment can be the best treatment for a given patient, non-operative patients do have deficits, and they do generally do worse functionally compared to a successful operation. All right, now we'll focus, when we get into surgery, we'll focus mostly on RIF, but a few words on arthroplasty. So first, reverse total shoulder arthroplasty is increasing relatively rapidly in the United States. And so this was a graph over the previous decade, and you can see the orange kind of up and to the right, so pretty substantial. So why is that? There's a lot of reasons for that. There are a number of randomized trials showing how reverse arthroplasty can be very effective in treating the geriatric proximal humerus fracture as an index procedure. When you look a little deeper into some of the literature, I just have a few kind of points here on these next few papers. So this is one, JSES 2020. So 60 patients were matched ORIF versus reverse total shoulder. The successful ORIF patients had better functional outcomes than reverse total shoulders, but in pretty much every single study, ORIF had a higher complication rate. And so just kind of something to keep in mind, ORIF can do best if we avoid complications. This is a meta-analysis from last year or 2 years ago now, 13 RCTs. Interestingly, ORIF in this paper showed the most improvement in DASH and pain scores. So we'll get into a little bit now ORIF. So we've decided the patient has a displaced and unstable fracture that would benefit from surgery, and they're able to participate in rehabilitation. We've decided that we think the assessment of the fracture and the assessment of our abilities that we can successfully fix that fracture. So we're going to go down this route now. So a ton of implants have been described historically. Probably a decade ago, I looked around the literature, and you can literally find like 50 implants described. And I pulled some. I found these crazy, like this spiral thing that goes up there. And this is all an indicator that nothing has worked particularly well over the years. So people are always looking for something new. And then the locking plate came out probably 20 years ago now, and this was thought to be the panacea. The way this worked with fixed angle screws, this is exactly what we needed to fix a proximal humerus fracture. So everybody was pretty excited about the potential for this to work. Turns out, so this is a meta-analysis or systematic review from some of the earliest series using lock plates for proximal humerus fractures. And it turned out the implant failures were extremely high, so double-digit, reoperation rate double-digit. And it started coming out, again, in some of these early series that the failure rate was directly related to the reduction accuracy. And so this was kind of, this paper and a few others around kind of this era started to kind of give us the idea that, like, you couldn't just malreduce a fracture and put on a lock plate and it would rescue your kind of generally technically poor surgery. All right, so we'll get into some of the details of the components. We'll start with tuberosity. So tuberosity reduction is critical. This is a great, I think, kind of visual and analogy by Ralph Hertel, who's a Swiss shoulder surgeon. And he has this egg cup idea where not only do we want to think about repositioning the tuberosities and stabilizing them there for the rotator cuff reasons, but also if we reestablish the ring, then we form a base to support the head on. And so it's a really cool concept to think about. We think about reducing them to each other, and it's interesting he shows the suture around them here. So here's a patient with a valgus type fracture pattern through a deltoid split approach. And so we're just here lifting the head up with an elevator, and then what we see is the space where the head was displaced. Now we've got the tuberosities splayed out. And so it's just a good demonstration of, I think, a good way to suture them back to each other. And then I guess ultimate point of all this is I think that if we rely on screws to fix tuberosity fragments, we can get burned. And so I have gotten burned, and you can create iatrogenic fracture lines, or you can expose non-displaced fracture lines. So pretty much for every tuberosity fracture now, we use the cuff insertion to make it kind of a soft tissue repair and kind of parachute the bone. And then most plates now have holes that we can tie our rotator cuff sutures to. Okay, so on now to the head and the neck reduction and kind of what we've learned over the years. So rules 1 through 5, I would say it's become very, very clear that we can't leave the OR with the humeral head in varus. And then kind of some secondary goals are to restore the kind of Shenton line of the shoulder, which again is not really truly described, but there is an arc up the calcar and up the neck of the scapula that should form an arc, and so we want to realign that region. So this was kind of one of the first clinical series out of Rochester with these new and exciting locked plates. And in their patients over 60 years old, 57% complication rate and 43% screw cutout. And this is one of the examples in their paper. They show this reduction, and then they show the failure. Like, here's an example of how these fail, but it's hard to imagine. This is like just when I was starting practice, and it's hard to imagine how we kept using this technique with like a 60% failure rate, but we figured out a lot since then. Here's a paper, also large series out of Denver, early days. 30% failure when we're in varus, 11% we're in valgus. This, like many papers, has shown that the failure risk is not due or not correlated or related to the number of screws that we use. So the answer is not filling up the head with screws generally. And then Southern California, this is the last one of this category. They focused on older patients, and they focused on varus fractures, and they noted that 79% complication rate in varus fractures, 21% perforation, but also in the kind of fine print buried in their discussion, they note that 71% were malreduced. So whether the problem with varus is holding them with our implants, or whether the problem is reducing them prior to our implants going in, we don't really know. It's probably a component of both. So just a few visuals on what I think are some helpful reduction techniques and also some landmarks of things we've been talking about. So here's that idea of the Shenton line. So now we've got a kind of mild varus fracture with the calcar disrupted. And so by working in the cancellous surface of the head, we can kind of quite simply lift the head back up onto the shaft and recreate this, what we think is a mechanically favorable situation so that our implants are kind of mechanically unloaded. So the valgus pattern is a little bit different. These are more common. There's less biological disruption, and they're a little bit easier to maintain mechanically. So I've generally similarly used an elevator when the medial hinge is intact like this. It makes life easier. And so here we've over-reduced it a little bit, so we let it settle back, and then we can fold that tuberosity in, and really things are pretty straightforward. Another very helpful tool, I think, which we use in many fractures, kind of in the metaphyseal regions, is the idea of like an indirect cortical reduction screw. And so here we've got the shaft over medialized, and once we get it in a position like this, assuming the plate is appropriately positioned, we can tighten and kind of dial this screw to pull the shaft to the plate just to get it to a position where we like it relative to the bone and relative to the medial calcar. One word of caution, this was a pretty cool study by a group who used the skeleton bone bank at the Cleveland Museum. They've got like 1,000 skeletons you can use academically for different things. So they tested the idea of like, if I use, based on just the last case relay, if I use a proximal humerus plate as a template for a reduction, is that going to be accurate? And they found that in many cases, the plate doesn't fit the bone, like we see anytime we put a anatomic plate on a bone, right? It's kind of one size fits none, and so you need to be careful when doing this technique. And sure enough, this came out, and I wasn't really thinking about it, but I had this happen to me. So this was a patient who we started using the plate as a template, and you can see what happened here is we've over-lateralized the shaft, and we want to avoid this. We think that even if the angle is not inverus, just uncovering this medial bone gives us an unstable situation. So in this case, we remedialize the shaft with a lamina spreader, again, kind of focusing on that calcar here, and then we lock the plate off bone. Another quick case, so this is also just a valgus type injury, higher energy. This was a young girl who had her elbow out the window and rolled the car over. And so a lot of different ways to sequence these, I would say. I've generally gone to trying to get the tuberosity, mainly the greater to start, to the head. And so we kind of mobilize the head with an elevator, mobilize the tuberosity with sutures. And then we need to check axillary views frequently. And so here we've got an elevator selectively placed posteriorly because we need to pay attention to this sagittal plane as well. One of the things that I think makes it difficult going back and forth and dealing with multiple planes as we've got kind of very light provisional fixation just can make things difficult. So now we've got the sagittal plane correct, we've got the tuberosity to the head, and we center the plate distally. And so now the next best time to check an axillary. So this is a different patient, but just to show that the most common deformity in the sagittal plane is this apex anterior. And so this situation in a surgical neck fracture helps to just elevate the shaft to the plate, as we do here, and then we can just basically reduce the shaft to the plate. In these anatomic neck fractures, it's often kind of increased retroversion that we need to correct. So we use our reduction screw, we pull the plate to the bone, and we end up with a reduction we're relatively happy with here. So just final case in a varus pattern. Again, these are the high risk, more often associated with medial comminution, less common, but more difficult to deal with. So just one kind of constellation slide of some thoughts for reduction techniques. So K-wires in the head can be used very effectively to kind of dial like a clock, the varus valgus or the coronal plane angulation. Sutures in the cuff, so even if they don't have a tuberosity fracture that benefits from cuff sutures, we can use cuff sutures to rotate the head around and mobilize the head fragment. An elevator here, and then arm abduction we can use to our advantage to adjust the neck shaft angle. And then again, our reduction screw to kind of center the shaft where we like it under the head, and then we make that shorter, and we're done here. All right, so now move on briefly to fixation. And so again, we've got strong deforming forces on very short segments in the humerus, so we've kind of got the deck stacked against us here, and we need to do things sometimes more than kind of standard lock plates, I think, to impart stable fixation. So again, osteopenic patients have exacerbated poor bone quality in the humeral head, and so therefore our implant anchorage is compromised many times. The humeral head in osteoporotic patients has been likened to a rotten tomato, a tennis ball, a rotten egg, and then one of my great early mentors, Dean Lorich, set this up in clinic one day and took this picture, and this is what we see clinically. This is a great analogy, and this is what we're trying to fight against. Is just, it's not a problem with the implant, it's the bone melts around our screws. So here's a patient who's 46, and you see pretty simple surgical neck fracture, moderately displaced. So he gets fixed like this, and I would say this patient, this fracture, there's a fair bit of room for error when it comes to reduction accuracy and implant placements and things like this, because this patient is going to heal. This patient, on the other hand, is very different, and so older, varus, medial comminution, etc. So these patients are very different, and I think when it comes to optimizing for success, we need to be able to recognize which patients are going to be high risk, what are the factors, and what's kind of the relative weight of those factors, so we can appropriately decide on, for example, non-op versus something, or arthroplasty versus ORIF, etc. So it's important to know what are the high-risk factors for failure. So one thing we learned that I mentioned a minute ago that's kind of been pervasive throughout the literature is that without high technical accuracy, we get higher rates of failure. So again, the lock plates or other implants we use don't overcome kind of poor surgery, which essentially comes down to poor reduction. So we still need to do kind of high quality surgery. So what are some of these risk factors that have come out in the literature over the years that have kind of combined to help us figure out which patients are best for which treatment? So one, turns out when you use a lateral kind of tension band plating mode and you've got unicortical screws, this implant is not able to offset this medial comminution very well. And so this kind of calcar unsupported comminution is very difficult for a plate to resist. And so this is a setup for high failure. Osteoporosis, like everywhere in the body, but especially it has been shown specifically in the humeral head. Initial varus, like we talked about, so this is high risk as well. Malreduction, so this has come up a number of times now, but malreduction has been shown to specifically be a risk factor for failure in the proximal humerus. And then this has been harder to quantify, but we know that the thinner, this is what I think is probably one of the best indications and most useful pieces of information to get from a CT scan, is the thickness of this head fragment. So you can see on the left here, now you have a good look at, like, can I anchor my screws into that right there? And the answer in this case, I would say probably not. So these are some of the risks. So what can we do then to offset some of these risk factors? Well, it's not just the kind of opposite of these, but anatomical reduction goes a long way. And so again, the things we're looking at are this calcar and this neck shaft angle. So if we can get a kind of a bony, inherent, stable reduction, we really have a much lower failure rate. All right, then there's this concept of this calcar screws. We looked at this 2007, a while ago now, and so the idea is that these low screws that you see right here can help to hold up the inferior head, and there's actually been some randomized trials looking at this now. And the idea is this kind of, what we think, this kind of older AO principle of, if you've got a rotten tomato, we don't want to hold it with our fingers from the top, but rather if we can get something fixed angle, the AO, it was related to a blade plate, underneath, it's going to help our mechanical situation a lot. And so these low screws have been shown over and over again to be helpful. Cement augmentation can help. Some reasonable data around this. Ken Eagle from New York about 10 years ago. This is kind of the one situation I've used cement, the kind of more extreme geriatric valgus patterns. When we derotate the head, we see now there's a big defect from all the cancellous impaction, and so there's a hole left behind, and so we want some sort of structural support to prevent kind of return of the head into its valgus position, and this can work very well. And then fibulostrate allograft. So this has been studied extensively to this point in the literature, also kind of some randomized trials, and seems to be very helpful. One most recently actually in JBJS. So I'll get briefly, just for a few minutes, a little bit of a detail into the fibular allograft. So in my mind, I think there's kind of three good indications and uses. Probably 90% of the time of these three, the indication I use it for is this first one. So patients who have this terrible triad of the proximal humerus, which is osteoporosis, varus, and then medial comminution. So this is the very high risk for failure patient. It's also very helpful, I would say, in surgical neck non-unions. And then we have these more complex kind of metadiaphyseal extensions, and I'll just show some brief examples of these. So here's the terrible triad patient we saw a minute ago too. This is the 78-year-old male, alcoholic, found down, and you can imagine this is going to be very difficult to maintain. So this is how we fixed him. So there's some low screws, the neck shaft angle looks pretty good, the plate's a little high, sagittal plane looks okay, but there's this big shark bite on the medial side like we talked about a minute ago, and so this right here could be a problem, and we've seen that the plates alone have a hard time minimizing the risk of deformity. So this patient does nothing, doesn't fall, who knows what he's doing, he did, but no main traumatic event, comes back in 6 weeks, and he's returned to his deformity position. So what we've done has failed him. And so looking at the way this failed, we may think that, the pull of the rotator cuff or the varus forces that caused the fracture have pulled on it again against our fixation, and it's obviously failed. But if we had this broad base, something that was not the threads of a locking screw, trying to offset this vector, we may help resist this deforming force. So next patient came in, and this was a 4-part kind of posterior medial roll-off fracture. And so now we think we're going to try to do something a little better than what we did for the last one. So we start with an elevator, lift the head back up, try to get the calcar docked, and so then we can kind of fine-tune the varus valgus. So we're going to start with our fibula. Given the schematic, we want to tilt this into the inferior head. You see here it's a little too long, so we can't tip it if it's too long. So take it back out, cut it, goes in from the lateral side, and then here's just some clinical pictures of it going in. I put this K-wire in kind of obliquely, just like for an axilla, for a tamp, to tamp it up into the head. But now it's shorter, and it can tilt. And so the way we saw the last one fail now, we think a strut in this position, again, may help minimize that. And then super paranoid, added cement in here as well and a bunch of screws. But this patient ended up going on to heal very well. So this really does make, I use this not a ton, probably 15 or 20% of the time, but it really does make these fractures just rock stable. You just don't see these moves. The other thing I would say, so I see a lot of fibulas being used in the literature and around the country, and a lot of times, they're kind of sticking down like this, and you can use them, I think, for different ways and different functions, but if you do want to use it to offset this varus, I think the vertical fibula sticking down the shaft, first of all, the arthroplasty guys hate it when they have to revise this, and it theoretically doesn't really do the mechanical work that we want it to. Here's another example of fractured calcar, leaving a big mechanical gap, and then you can see the fibula here is the perfect substitution for the calcar, and then we get this rock stable kind of construct here. So non-unions, surgical neck non-unions work very well. This was a patient who I had this reduction, I guess I took out the fluoros, but I had this reduction on the AP, and you can see this gap. I thought I had over-distracted this humerus, given the 2-centimeter gap. But you look in the axillary view, it's not over-distracted. It's just bone loss that happens in a lot of these humeri. And so you can see, again, kind of the substitution function of the fibula is very helpful in this situation. And then finally, metadiaphyseal comminution, I think, is a great indication. This is more of a geriatric pattern, this kind of extensive spiral. And so lagging back, it's hard to bridge mode plate. These kind of fractures, lagging these individual fragments back is also difficult in this osteoporotic bone. So fibula fits very well into the humeral intramedullary canal, and it essentially, in this function, just works as a template with these barrel staves to just tack the bone back to and kind of rebuild it back up. And then the other extreme, but similar function, this is the kind of high energy exploded, and it again functions as a good template starting point just to start sticking the pieces back onto and get to something that somewhat resembles a proximal humerus. Okay, so that's a lot. We'll end now with, again, there's hundreds and hundreds just in the last few years, but what I think are kind of 6 helpful studies that I've kind of read multiple times now, and I think have really impacted the way I've seen this body of literature. So first, the Proffer trial. It's amazing. This has been 9 years now. I remember clearly when this was presented at the OTA to the response of gasps and oh my goshes. And so this was a multi-center study from the UK, 230 patients, displaced proximal humerus fractures, and they were randomized to operative versus non-operative treatment. You can see what they did here, a smattering, mostly lock plates, 2 years, no difference. JAMA conclusion is shoulder surgery doesn't work for proximal humerus fractures. That's literally the conclusion. And so, yeah, obviously people were very scrutinizing of like how they did, and I would say there really is a lot of validity to the rebuttals to this paper, more than just like surgeons want to keep doing surgery. So there's 66 surgeons in this. The median was one surgeon one case per surgeon in the study. This is not necessarily like a methodological critique. This is a pragmatic study. But, so given everything we've talked about in the last 45 minutes, kind of what the literature has shown us about the importance of reduction. So they don't look at all at reduction. They don't quantify or comment at all on reduction. We know that poor reduction leads to high risk of failure, poor outcomes. And then really probably what I think the most important thing is, which is, again, not like a critique of the data or fault of the authors, but just important to remember about this study is that these patients were excluded if the surgeon thought there was a clear indication for surgery. So if the patient was displaced and they said, I think this needs surgery, well, then you're not eligible for the study. So the patients enrolled here are patients in whom we didn't really know what to do. They were like on the fence for indication anyway. So anyway, this study, obviously there was a lot of letters to the editor and a lot of discussion, and so it's still out there, and the proffer is important to be aware of. And anyway, and there was a 5-year follow-up, which also, again, showed no difference. This is a really interesting paper out of Germany. Looked at 98 patients, 3 and 4 part fractures, followed for 3 years. And so again, very little of the proximal humerus outcome studies looks at reduction quality. And so this is one of the main problems with a lot of this literature. But these authors kind of sought to do this. And so they quantified reduction quality, looked at outcomes, and they found that reduction quality was the only variable that significantly affected complication and reoperation rate. So pretty interesting. Number 3, so this is, I think, also a really cool idea. This group from Montreal, kind of seeing all of this piecemeal in the literature, like I've talked about, they kind of looked at all these factors in one series, and they came up with just a helpful list of things to do. One was, don't put in head screws greater than 45. So people would talk about, well, we don't want them right up to the subchondral bone, like we do in the femoral head because we get easier penetration, et cetera. So we don't want to lateralize the shaft. Lack of medial support is a problem. Varus reduction is a problem. So kind of everything that kind of wrapped up into one study. So these next 2 studies from Mike Robinson, who's just a really awesome surgeon and has done some great work and really advanced the field, I would say, maybe more than anyone. So this study, so they have a very high volume referral center in the UK, in Edinburgh. So he looked at 5,900 referrals, 368 were operative. So just to give you a sense, again, everything we've talked about, high volume expert surgeon, and this is his numerator and denominator. So still vast majority are non-op. He came up with a kind of a protocol, indications for surgery, fracture dislocation, tuberosity greater than a centimeter. We often hear 5 millimeters. He used a centimeter, 100% shaft displacement. And then this is unfortunately the vague one is the severe varus valgus. But using this protocol, which again is kind of more significant displacement than some, he had a 6.8% failure or non-union rate and a 4% AVN rate. Now again, he's an expert surgeon technically, but the idea was to show that using a protocolized approach, you can get good results if you kind of pick the right patients to operate on. So really pretty interesting. Here's another just really interesting paper, another factor that people haven't talked about enough and studied enough, looking at the outcomes of non-operative proximal humerus fractures in 774 patients. And so he found, a lot of studies are kind of like, oh, it's average pretty good or average not, but he found it's highly variable. And more importantly, he found that it's most dependent upon social deprivation scores, mood disorders, and so they used a kind of a novel technique for analysis of like which factors account for what percentage of the variation. And so the psychological factors accounted for by far the most of the variation. And so all the things, the technical radiographic measurements we've been talking about, translation, tuberosity, displacement, et cetera, counted for like single-digit % of the outcome. So things that we don't think about too often. All right, and then really my favorite study of them all, this is Christian Krettek's group out of Germany. Non-census in the treatment of proximal humerus fractures, uncontrolled blinded comparative analysis between Homo chirurgicus, which is orthopedic trauma surgeon, and Macaca sylvanus, which is a Barbary macaque monkey. So they took 9 cases, and they have decisions whether you do non-op or operative, which procedure, and outcome of conservative treatment, good or bad. So here's what they did. They put the options for the monkeys with food trays. Whichever food tray they went to, that was what they thought would be the treatment of choice. This is in BMJ 2020. What they found was the inter-rater reliability was poor, but the prediction of outcome scores among orthopedic surgeons was way worse compared to the monkeys. So there's still a lot that we don't know, and so great study. So just to wrap up, going all the way back to the very beginning, didn't talk much about imaging, but we need to fully understand the fracture. Sometimes that's a CT with a 3D. Get what you need to fully understand. Careful patient selection. Again, we talked about kind of indicators of instability, and it's important to assess all that, but really it just all depends on the patient and what they need. Critical to understand and assess the prognostic factors, just to really kind of hammer it in. Again, it's varus, calcar comminution, and osteoporosis are the risk factors. Whatever approach we do, we need to do a biologically friendly dissection. Didn't talk much about surgical approaches. Can't overstate the importance of reduction quality. Implant position is important. Low, long screws, cuff sutures are helpful. And then in the complex or high-risk cases that we want to fix, these are the ones where we start to think about augmentation, cement, oblique fibula, vertical fibula, et cetera. And that's it. Thank you very much.
Thanks, Mike. Give me time for questions, Bob.
Thanks a lot. When you see talks like this done by people who are experts, and it's like, if you do it right, you can get a good result. The problem is just doing it right. How do you feel reverse fits in your armamentarium? You didn't say much about it, and when you're talking 78, 80-year-old and some of the patients, you might say that's an option. So where does that fit in your?
Yeah, totally. Yep. Right. So
Yeah, so this is one of the interesting things about this is that, so I'm a trauma surgeon. I don't do reverse arthroplasty. I have colleagues who do, and I refer to them. But that also kind of biases, my indications. It biases the literature. You look at the outcomes in a paper, and you need to see what kind of surgeon, wrote this and did these papers. Anyway, so in my practice, there's a very, there's a major place for reverse arthroplasty. Now, I don't do it, so I refer them out. Maybe I didn't talk as much about the indications for reverse, but for me, it's got to be a little older. It's kind of over than 70, physiologic, but also just kind of the average bone quality. It's not over 65, but 70 or 75, and then it's kind of the small head fragment, small anatomic neck with thin bone. Those are just kind of the general things and features that I will plan to set up a reverse arthroplasty for a patient. But it's a good operation. Patients do very well. The complications are disastrous. Instability after fracture has been shown as like 25-30% in some series. But again, in a lot of patients, it's by far the best option. Yeah. So I don't mean to downplay it by omitting a lot of discussion in my talk. There's an important role it plays. Yeah.
Hey, sir. If you have a younger active adult with like a head split, I didn't see any discussion on hemiarthroplasty for those patients. Major considerations were for active adults.
Yep.
For having.
Good question. Yeah. So the head split. So I guess in my mind, the that hemi for head split, is a little bit historical, and so we don't really do hemis in young adults anymore. I think our understanding of the anatomy and fracture patterns and imaging quality and ability to get, for example, to the articular surface in a young patient, whereas in the past it was just like, this is too complex, we can't put it back together. Now we've got approaches, we've got implants, and things have just evolved so that we're now fixing those patients. Depending, you can use joysticks and fluoroscopy. There's a description by Andy Chu, who's a kind of shoulder / trauma surgeon in Houston, talks about a peel of the subscap. And just like you do for an arthroplasty, but you externally rotate, look at the joint, put it back together, and then fix the soft tissues. So there are ways to fix it. And, no one has a huge experience in the relatively uncommon fracture pattern, but I would say hemi is really fallen out of favor.
Thanks, sir.
Yeah, thanks for the question. Yeah.
Hey, thanks, Mike. That was pretty good. Can you talk a little bit about the choice of approach between the delta pectoral and the deltoid split, what it changes with their size patterns?
Yeah, thanks. So yeah, I took a lot of that out of this, but yeah, so I've gone to a deltoid split approach for pretty much everything now. In my mind, it's kind of comes one interval around the, through the deltoid instead of in front of it, to the fracture pathology and to the plate application zone. And it makes reduction easier for me, and I think is a little more biologically friendly. Are the reasons. The times I will do a delta pectoral approach is if there's a lesser tuberosity fragment. So through a deltoid split, it's a little harder to get to the lesser, to reduce to access and displace lesser tuberosity fragment. So if there's medialization that's pretty significant, I'll do delta pec. If it's a non-union situation and we really need to be aggressively debriding surgical neck, I'll do it then. Probably the most important one, I think, is the juxtathoracic fracture dislocation. And so we get CT angios for all of these patients, and it's gasp worthy when you see it's always the vessel
lays right over these, like, the fracture surfaces, like, every time. We've had 4 of them in the last 6 months for whatever reason. And so that, you need a vascularly extensile exposure of a delta pec. Yeah, so there's a lot of, and then like the subsequent arthroplasty through that, that comes up. And so there's a lot of issues around which approach and when, but I've kind of gone all deltoid split. Yeah.
So your indications to not deltoid split would be the head's medial to the glenoid or the lesser's medial to the glenoid.
Yeah, or a surgical neck non-union.
Or non-
Yeah, even for fractures that extend distal, it's this extensile down to the radial nerve and past that, so it's extensile laterally too. So, yeah. Are you guys doing here, kind of beach chair or supine positioning?
You all mind position?
Yeah, seems like kind of a trauma thing, no beach chairs.
Yeah, I think probably some of our sports colleagues probably still do some more beach chair.
Yeah,
Don't speak for them.
Get a good accelerated lateral each chair position.
yeah,
And
Agreed.
rely on that to not have the apex anterior deformity, so confidence.
Totally. I agree.
I could talk, sorry, Justin, go ahead.
Yep, like, so is the current technology like plates and nails using some of the things you recommend to achieve an adequate reduction? Do you think our technology is adequate to have success, or do you think we need to have some advancement in what we use?
yeah, I mean, it's crazy to me that we haven't gone beyond plates and screws now. Yet, given the high failure rate, given the common fracture pattern, that there hasn't been some just kind of something that looks and acts completely different than a plate and screws. I mean, like, the innovations have been like variable angle Calcar screws and, more suture holds. It's like, yeah, so it would seem like a wholesale change would be time.
To Justin's question, I think about homologs like upper extremity and lower extremity, and this is the hip all over again, right? I mean, the varus reduction will kill you, cut out will kill you, and in both locations, something that hasn't taken hold, which is thinking differently than plates and screws, is some sort of augmentation. And you showed some examples, but in the hip and in the shoulder, it's never gotten any traction, right?
Yeah.
I mean, people are routinely, and why not?
Yeah.
Why do you think that is?
Yeah, I'm not sure. So I was using for a while, also, it's got some good, interesting case I took out, but this one company had this it was like a dual layer nitinol balloon, like a cardiac stent. But it functioned how, like, we see the failures, like this makes sense for that. It's volumetric, it's not rigid, resist varus, and it worked great. And there were fractures I absolutely fixed with that thing that I would not have, not having that. And so it seemed, but then it was too expensive to manufacture because not every, hospital wants to pay for a double cardiac stent for a shoulder fracture. And so they didn't have the business model around, so they discontinued it. And so it's hard. There's a cost to innovation, which is sometimes prohibitive as well.
Any other questions? All right, Mike's gonna do a second hour with the residents. We very much appreciate him coming. Thank you very much.
Thank you, guys.